Hi, I'm Dr. Robert Coleman. I'm a gynecologic oncologist and the Chief Scientific Officer at U.S. Oncology Research. I'm so excited to share with you the PAOLA-1 trial, which is the first phase 3 trial to investigate a PARP inhibitor plus bevacizumab for the maintenance treatment of women with advanced ovarian cancer. There is an urgent need to improve the management of advanced ovarian cancer following response to first-line chemotherapy. Despite curative intent, it is estimated 70% of patients with advanced ovarian cancer will relapse within 3 years after first-line chemotherapy regimen. Also, the 5-year survival rate is only 29%, and relapsed patients are often incurable. SOLO-1 was the first study of a PARP inhibitor to demonstrate an unprecedented efficacy of Lynparza versus placebo in women with newly diagnosed BRCA-mutated advanced ovarian cancer who were in response to first-line platinum-based chemotherapy. After a median follow-up of 41 months, median progression-free survival wasn't reached in the Lynparza arm versus 13.8 months in the placebo arm. Overall, adverse reactions in SOLO-1 were generally consistent with the known safety profiles of Lynparza. Some of the most common adverse reactions in SOLO-1 included nausea, vomiting, and fatigue. The PAOLA-1 study builds on the practice-changing results of SOLO-1 by including patients who are HRD positive regardless of the BRCA mutation status. About 1 in 2 women with advanced ovarian cancer have homologous recombination deficiency, or HRD. HRD can be caused by mutations within genes integral to the homologous recombination repair pathway, such as BRCA1 and BRCA2, which are found in approximately 25% of women with epithelial ovarian cancer. An additional 25% of women with epithelial ovarian cancer may have other disruptions to the HRR pathway, such as altered gene expression leading to HRD. Therefore, all women with a BRCA mutation are HRD positive, but not all women who are HRD positive have a BRCA mutation. Let's review the PAOLA-1 study design. PAOLA-1 compared the efficacy and safety of Lynparza plus bevacizumab versus bevacizumab alone for the maintenance treatment of women with advanced ovarian cancer following complete or partial response to first-line platinum-based chemotherapy and bevacizumab. The study enrolled women with stage 3-4 high-grade serous or endometrioid ovarian cancer with or without a BRCA mutation. Bevacizumab was given at the standard dose of 15 milligrams per kilogram every 3 weeks and was combined with platinum-based chemotherapy at the initiation of treatment and continued after randomization as maintenance therapy for a total duration of up to 15 months. Lynparza was administered at the standard dose of 300 milligrams twice daily for up to 2 years. The primary endpoint was investigator-assessed PFS. Approximately half of the patients in PAOLA-1 were HRD positive, defined as either a tumor BRCA mutation and/or an HRD genomic instability score of greater than or equal to 42 by Myriad MyChoice HRD Plus test. 29% of patients had deleterious tumor BRCA mutations, and 19% had non-BRCA mutated HRD positive tumors. The following efficacy results are based on a pre-specified exploratory subgroup analysis of 387 patients with HRD positive tumors identified post-randomization using the Myriad MyChoice HRD Plus test. The median duration of follow-up was 27.4 months in the Lynparza plus bevacizumab arm versus 27.5 months in the bevacizumab plus placebo arm. The subgroup analysis showed that Lynparza plus bevacizumab demonstrated the greatest clinical benefit in the HRD positive population, with a median PFS of 37.2 months compared to 17.7 months versus bevacizumab plus placebo. Please note that the HRD subgroup analysis may have potential statistical and imbalance biases. 8 out of 10 women remained on Lynparza plus bevacizumab as prescribed, without discontinuing due to adverse reactions. Adverse reactions in PAOLA-1 were mostly grades 1 and 2 and were generally consistent with the known safety profiles of Lynparza. The most common adverse reactions, greater than or equal to 10%, for patients receiving Lynparza plus bevacizumab were nausea, fatigue, including asthenia, anemia, lymphopenia, vomiting, diarrhea, neutropenia, leukopenia, urinary tract infection, and headache.
Fatal adverse reactions occurred in 1 patient due to concurrent pneumonia and aplastic anemia. Serious adverse reactions occurred in 31% of patients who received Lynparza plus bevacizumab. Serious adverse reactions in greater than 5% of patients included hypertension and anemia.
Laboratory abnormalities were also consistent with the known safety profiles of Lynparza. So what is the significance of the PAOLA-1 results and the FDA indication? First, the PAOLA-1 trial supports the importance of targeted treatment strategies. Knowing a patient's HRD status allows physicians to select appropriate induction and maintenance treatments. Therefore, consider HRD tumor testing in all your newly diagnosed patients with ovarian cancer. Second, PAOLA-1 is the first phase 3 PARP inhibitor plus bevacizumab maintenance trial that included patients with HRD-positive tumors regardless of the BRCA mutation status. This extends the use of Lynparza to patients with HRD-positive tumors that do not have a BRCA mutation. Therefore, choose Lynparza plus bevacizumab for first-line maintenance therapy for all appropriate patients with HRD-positive advanced ovarian cancer.
The PAOLA-1 results led to the FDA approval of Lynparza in combination with bevacizumab for the maintenance treatment of adult patients with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with homologous recombination deficiency HRD-positive status, defined by either a deleterious or suspected deleterious BRCA mutation, and/or genomic instability. Select patients for therapy based on an FDA-approved companion diagnostic for Lynparza. Important safety information. Contraindications. There are no contraindications for Lynparza. Warnings and precautions. Myelodysplastic syndrome or acute myeloid leukemia, MDS or AML, occurred in less than 1.5% of patients exposed to Lynparza monotherapy, and the majority of events had a fatal outcome. The duration of therapy in patients who developed secondary MDS or AML varied from less than 6 months to greater than 2 years. All of these patients had previous chemotherapy with platinum agents and/or other DNA-damaging agents, including radiotherapy, and some also had a history of more than one primary malignancy or of bone marrow dysplasia. Do not start Lynparza until patients have recovered from hematological toxicity caused by previous chemotherapy, less than or equal to grade 1. Monitor complete blood count for cytopenia at baseline and monthly thereafter for clinically significant changes during treatment. For prolonged hematological toxicities, interrupt Lynparza and monitor blood count weekly until recovery. If the levels have not recovered to grade 1 or less after 4 weeks, refer the patient to a hematologist for further investigations, including bone marrow analysis and blood sample for cytogenetics. Discontinue Lynparza if MDS or AML is confirmed. Pneumonitis occurred in less than 1% of patients exposed to Lynparza, and some cases were fatal. If patients present with new or worsening respiratory symptoms such as dyspnea, cough, and fever, or a radiological abnormality occurs, interrupt Lynparza treatment and initiate prompt investigation. Discontinue Lynparza if pneumonitis is confirmed and treat patient appropriately. Embryo-fetal toxicity. Based on its mechanism of action and findings in animals, Lynparza can cause fetal harm. A pregnancy test is recommended for females of reproductive potential prior to initiating treatment. Females. Advise females of reproductive potential of the potential risk to a fetus and to use effective contraception during treatment and for 6 months following the last dose. Adverse reactions. First-line maintenance BRCA-mutated advanced ovarian cancer. Most common adverse reactions, grades 1 to 4, in greater than or equal to 10% of patients in clinical trials of Lynparza in the first-line maintenance setting for SOLO-1 were nausea 77%, fatigue 67%, abdominal pain 45%, vomiting 40%, anemia 38%, diarrhea 37%, constipation 28%, upper respiratory tract infection, influenza, nasopharyngitis, bronchitis 28%, dysgeusia 26%, decreased appetite 20%, dizziness 20%, neutropenia 17%, dyspepsia 17%, dyspnea 15%, leukopenia 13%, UTI 13%, thrombocytopenia 11%, and stomatitis 11%. Most common laboratory abnormalities, grades 1 to 4, in greater than or equal to 25% of patients in clinical trials of Lynparza in the first-line maintenance setting for SOLO-1 were decrease in hemoglobin 87%, increase in mean corpuscular volume 87%, decrease in leukocytes 70%, decrease in lymphocytes 67%, decrease in absolute neutrophil count 51%, decrease in platelets 35%, an increase in serum creatinine 34%. Adverse reactions. First-line maintenance advanced ovarian cancer in combination with bevacizumab. Most common adverse reactions, grades 1 to 4, in greater than or equal to 10% of patients treated with Lynparza plus bevacizumab, compared to a greater than or equal to 5% frequency for placebo plus bevacizumab in the first-line maintenance setting for PAOLA-1 were nausea 53%, fatigue, including asthenia 53%, anemia 41%, lymphopenia 24%, vomiting 22%, and leukopenia 18%. In addition, the most common adverse reactions, greater than or equal to 10% for patients receiving Lynparza plus bevacizumab, irrespective of the frequency compared with the placebo plus bevacizumab arm, were diarrhea 18%, neutropenia 18%, urinary tract infection 15%, and headache 14%. In addition, venous thromboembolic events occurred more commonly in patients receiving Lynparza plus bevacizumab, 5%, than in those receiving placebo plus bevacizumab, 1.9%. Most common laboratory abnormalities, grades 1 to 4, in greater than or equal to 25% of patients for Lynparza in combination with bevacizumab in the first-line maintenance setting for PAOLA-1 were decrease in hemoglobin, 79%, decrease in lymphocytes, 63%, increase in serum creatinine, 61%, decrease in leukocytes, 59%, decrease in absolute neutrophil count, 35%, and decrease in platelets, 35%. Drug interactions. Anti-cancer agents. Clinical studies of Lynparza in combination with other myelosuppressive anti-cancer agents, including DNA-damaging agents, indicate a potentiation and prolongation of myelosuppressive toxicity. CYP3A inhibitors. Avoid concomitant use of strong or moderate CYP3A inhibitors. If a strong or moderate CYP3A inhibitor must be co-administered, reduce the dose of Lynparza. Advise patients to avoid grapefruit, grapefruit juice, Seville oranges, and Seville orange juice during Lynparza treatment. CYP3A inducers. Avoid concomitant use of strong or moderate CYP3A inducers when using Lynparza. If a moderate inducer cannot be avoided, there is a potential for decreased efficacy of Lynparza. Use in specific populations. Lactation. No data are available regarding the presence of olaparib in human milk, its effects on the breastfed infant, or on milk production. Because of the potential for serious adverse reactions in the breastfed infant, advise a lactating woman not to breastfeed during treatment with Lynparza and for 1 month after receiving the final dose. Pediatric use. The safety and efficacy of Lynparza have not been established in pediatric patients. Hepatic impairment. No adjustment to the starting dose is required in patients with mild or moderate hepatic impairment. Child-Pugh classification A and B. There are no data in patients with severe hepatic impairment. Child-Pugh classification C. Renal impairment. No dosage modification is recommended in patients with mild renal impairment. Clearance creatinine 51 to 80 milliliters per minute, estimated by Cockcroft-Gault. In patients with moderate renal impairment, clearance creatinine 31 to 50 milliliters per minute. Reduce the dose of Lynparza to 200 milligrams twice daily. There are no data in patients with severe renal impairment or end-stage renal disease. Clearance creatinine less than or equal to 30 milliliters per minute. Indications. Lynparza is a poly-ADP ribose polymerase PARP inhibitor indicated first-line maintenance BRCA-mutated advanced ovarian cancer for the maintenance treatment of adult patients with deleterious or suspected deleterious germline or somatic BRCA-mutated, G-BRCA-mutated, or S-BRCA-mutated advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are incomplete or partial response to first-line platinum-based chemotherapy. Select patients for therapy based on an FDA-approved companion diagnostic for Lynparza. first-line maintenance HRD-positive advanced ovarian cancer in combination with bevacizumab. In combination with bevacizumab for the maintenance treatment of adult patients with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with homologous recombination deficiency HRD-positive status, defined by either a deleterious or suspected deleterious BRCA mutation and/or genomic instability. Select patients for therapy based on an FDA-approved companion diagnostic for Lynparza. Please see complete prescribing information, including patient information, medication guide. Thank you for watching this presentation. For more information about the PAOLA-1 study and for the Lynparza prescribing information, please visit lynparzahcp.com or call 1-877-893-1510.